minutes. Warning. You can choose the language of your preference using the icon button for interpretation. Diabetes, the art of insulin treatment, past, present, and future. We are beginning. Good morning, everyone. Welcome to this webinar organized by the Latin American Federation of Endocrinology on diabetes, past, present, and future of diabetes treatment. I am Dr. Fred Cavallo from Costa Rica, and I'm president of the Society for Endocrinology. I will mention some aspects that are relevant to the session. It's very important to keep your microphones muted. We have simultaneous interpretation for English and Spanish available in the globe in the bottom part of your screen. We will have questions we received previous to our webinar. We will answer them at the end, and we also invite you to add them in the bottom in the chat box during the presentation. Certificates will be given for the continuous attendance, and our team will verify at the end of the webinar. The webinar will be uploaded on our webpage and YouTube and on the International Society of Education, which is sponsoring us. Now, I would like to introduce you to Dr. Alvarado, Jose Napoleon Alvarado Renderos from El Salvador. He will share the coordination on this occasion. I will give the floor to Dr. Alvarado, so he will introduce us to our next speaker. Good morning, everyone. Warm welcome from El Salvador. Thank you very much, Dr. Cavallo, for your presentation. For me, it's an honor to introduce you to Dr. Chih Hao Chen Ku, who is here with us from our Republic of Costa Rica. He is an endocrinologist, surgeon, and he's a specialist in endocrinology, and he's professor at the Department of Pharmacology and Clinical Toxicology at the University of Costa Rica, and in the postgraduate systems in the specialty of endocrinology and internal medicine. He's also a research of multiple international studies on diabetes mellitus, osteoporosis, and cardiovascular disease. Remember that at the end, we will have a Q&A session. And now I will give the floor to Dr. Chen Ku. Welcome, Dr. Chen. It's a pleasure to have you with us. Hello, everyone. First of all, I would like to thank the Latin American Federation of Endocrinology for the kind invitation and Dr. Napoleon Alvarado for the introduction. Today, we're going to talk about the art of insulin treatment, past, present, and future. These are my conflicts of interest. I have been a lecturer for many companies that have to do with the area of diabetes, and in relation to the insulin topic that we are going to see today, I have been a lecturer directly. So we are going to see what have been the paradigm changes been over the years in insulin treatment, the advent of insulin analogs, and how did this change the way in which we treat, especially in type 2 diabetes, and what are the insulins that are coming in the future. There are two that are already around the corner. So let's start with the past. As you know, insulin was discovered in 1921 by these two doctors, well, a medical student and a doctor, Frederick Banting and Charles Best. A curious fact is that insulin is the only molecule that throughout the history of medicine has received 3 Nobel Prizes. So initially, Banting and MacLeod, who was Banting's director, they shared the Nobel Prize in solidarity with Best, who was a Mexico student. They received a Nobel Prize for the discovery of insulin. Then Frederick Sander received a Nobel Prize for determining the amino acid sequence for insulin. And finally, Rosalind Yallo and Solomon Burton received a Nobel Prize in medicine and physiology for the radioimmunoassay to measure insulin. So let's see how important it has been that 3 Nobel Prizes have been dedicated to insulin. The first administration in human beings was January 11, 1922, and a simple insulin was administered twice a day with volumes between 5 and 18 cc. So imagine injecting 10 cc twice a day with needles of this type. So initially what was administered between 1922 and 1936 was basically simple insulin. The other detail to take into account is that at that time, the extract was alcohol-based. So imagine the pain injecting twice a day these volumes of alcohol with insulin. NPH appeared in 1936 In 1954, slow insulin appeared, and then ultra slow insulin appeared, and this was withdrawn from the world market in the early 2000s. The paradigm in the mid-1990s is insulin is administered, especially NPH, between 2 and twice a day to keep the patient as asymptomatic. And basically, what they were looking for is that the patient had no polynuria, no polydipsia, especially for patients with type 1 diabetes, no ketosis. Let's focus on that time, what was when the first glucose monitors were just coming to market with glucometers that took blood samples on fingers. So the objective of the treatment was for the patient to be asymptomatic and not to have osmotic diuresis and to have negative glycuria. So really, until the early 90s, the impact that bringing glycemia to near normal could have on the risk of complications was not known, and there were people who didn't think that it could impact the risk of complications. The whole story changed in 1993 when this landmark study appeared. This pivotal study, which is the DCCT, or Diabetes Complications and Control Trial, that is a pivotal study of type 1 diabetes, where they took patients with newly diagnosed type 1 diabetes, and one group was given a conventional treatment, which was 2 doses of NPH, versus the other group that received an insulin treatment. It was found it was 4 daily applications, where 3 was plain insulin and 1 NPH, or insulin microinfuser, what we know as insulin pumps. What the DCT showed at that time was that the intensively treated group managed to lower the glycated hemoglobin to 7%, and there is a 2% difference in the glycated hemoglobin. And this was clearly associated with a reduction in the risk of retinopathy and nephropathy. And this is both in primary prevention or prevention of the first appearance of any of these complications. This was the first demonstration that indeed intensive treatment close to normal glycemia in patients with type 1 diabetes could prevent complications. However, it immediately became clear, since we knew at that time that just as lowering glucose reduced complications, lowering glucose increased the risk of hypoglycemia, especially severe hypoglycemia. So that is what we should try to avoid. The price to pay with the insulin available at that time was that the closer to normal glycemia, the greater the risk of hypoglycemia. Let's move on to the present. Human insulin that we have today are the simple insulin that everyone knows. We have all used them with an onset of action from 30 to 60 minutes, with a peak of action from 2 to 4 hours, duration of action from 6 to 8 hours, and the NPH that starts between 1 to 2 hours later, with peak of action from 5 to 7 hours, duration of action from 13 to 18 hours. And the problem is that with this peak action of NPH, the risk of nocturnal hypoglycemia increases. And for practical purposes, imagine this with simple insulin. When we have a small child, for example, that we have to administer it 30 minutes before a meal, telling the child to wait 30 minutes to eat. In these 30 minutes, everything happens. For example, the child starts to eat, let's say because he is very hungry, or he is no longer hungry, so he does not eat. And if we have already given him insulin, this increases the risk of hypoglycemia. So waiting 30 to 60 minutes to eat, then inject, and then waiting. That schedule to eat is not very practical in real time. So at the end of the night, is the first insulin analogs appeared, then ultra-fast acting insulin analogs. What they do is to modify the amino acid sequence of human insulin precisely so that instead of forming hexameters, they form dimers, and that makes absorption faster. So we have 3 in the world market today, that is lyso, aspart, and glycerin. They start to act about 5 to 15 minutes after administration, with a peak of action of 1 to 2 hours and a duration of action of about 4 to 5 hours. Also, on these ultra-fast analogs, there are 2 different formulations that are already approved in the most developed countries. One is PS, and then comes aspart from a faster onset of action. And there is the same insulin aspart. What changes is that they have 2 excipients. One is arginine, and the other one is niacinamide. And what this does is to increase blood flow in the subcutaneous space to accelerate absorption. If we see the kinetics of PS compared to insulin aspart, the peak action action is about 5 minutes earlier than the onset of the aspart. So we see how the onset of action is slightly faster, and there is also another one called ultra-rapid lispro. It uses a similar technology where we have two excipients, which is in this case are citrate and treprostinil, which is what is done is again produce local vasodilation, increase blood flow, increase vascular permeability, and allows absorption to the faster. And then we compare the ultra rapid Lispro versus the regular Lispro, then there's a difference of about 5 minutes or so in the onset of the action and the peak of action. However, for practical purposes, they are not at all that different. Even patients who have used these insulins in microneedles and insulin pumps, today there is no major difference compared to the ultra-fast analogs. We also have inhaled insulin. They have been two inhaled insulins, which was withdrawn from the market because of changes in lung volumes, and this other one, which is still available today. This is a trademark name of this one. It's called Afria. It allows the faster absorption through the airway, through the alveoli, make the peak with a much faster onset of action. So it stimulates very much this first phase of insulin secretion that we see in a person who does not have diabetes. However, the awkward thing is that it is inhaled, but it would eventually replace the rapid acting insulin, but the patient still has to inject the basal insulin. And then in the late 1990s, early 2000s, Bailey insulin analog came along. The first one to appear and the one that changed the paradigms of how we insulinize type 2 diabetes was Glargine U100, which had a duration of action of 20 hours. Then a more concentrated formulation than Glargine U100 appeared, which is Glargine U300, which has a lower peak of action and a flatter peak of action, and the duration of action is extended to 24 hours. We also have insulin dedimir, which lasts about 12 to 20 hours. So in about 1/3 of patients with type 1 diabetes, the dose of dedimir has to be fractioned to twice a day because it does not cover the 24 hours. And then we have insulin degludec. These came to change a lot how we insulinize type 2 diabetes today, and it taught us a lot of things, these basal insulin. What did it come to revolutionize? How we start insulinizing patients with type 2 diabetes is a study that is called Treat to Target. Before that, consider that the definition of the unit of insulin when it appeared initially, what we had in 1922, was based on bioassays, and a unit of insulin was defined as the amount of insulin necessary to lower 45 milligrams per deciliter of glucose in 5 hours in a 2-pound rapid. And the current, more standardized definition is that a unit of insulin corresponds to the activity contained in 1/22 milligrams of insulin zinc crystals. Why is this important? Because you see that this is by activity. 1 unit of insulin X has the same activity of 1 unit of insulin Y. What can change is that if insulin Y has a lower affinity for the receptor, it may require more molecules, more moles to reach the same activity of the unit of insulin, but 1 unit between 2 insulins is the same, and it's important because of what we're going to see. The study that came to change the paradigm in the treatment of insulinization and type 2 diabetes is that study from 2003, which is the Treat to Target study. And here it compared NPH insulin versus insulin glargine in patients with type 2 diabetes who were uncontrolled on oral agents. The first thing we see here is that the fasting plasma glucose reduced equally. The glycated hemoglobin was equal, but insulin glargine, having a flatter effect and not having the peak action of NPH, was associated with a much lower risk of hypoglycemia, whatever the definition of hypoglycemia was, whether it was 56 milligrams or 72 milligrams. So the price we were paying for having normal glycemia, which was hypoglycemia, was less with basal insulin analogs. Then with the other trials, we are very accustomed to using insulin as a last line therapy. However, in Asia, there are a number of studies that indicate that very early use of insulin actually preserves beta cells. That was the first study done in Hong Kong. They took took patients with
Les
newly
dieron 2
diagnosed
semanas de
type 2
tratamiento y
diabetes. One
suspendieron
group
el
was put on
tratamiento.
oral agents,
Entonces, y lo siguieron
others
por
on
50 semanas
subcutaneous
más.
infusion of
Entonces, ojo,
insulin,
2
and the
semanas de
other on an
tratamiento y luego 50
intensified
semanas sin
insulin
tratamiento.
schedule.
Y el
They
objetivo
were
del
given
estudio era
2
ver
weeks of
remisión del
treatment and
diabetes, o
then
sea, cuántos
discontinued
pacientes se
treatment,
mantenían
and they
normoglicémicos.
continued it for
Y vean
50
cómo
more
al
weeks.
final de un
So
año,
mind
los
you,
pacientes
2
que
weeks
estaban
of
utilizando
treatment and then
insulina
50 weeks
tenían
of
mayor
no
probabilidad de
treatment.
estar en
And the
remisión
objective of the
comparado con los
study
que
was
estaban
to
en
see
inmunoglobulina.
diabetes
Y esto es casi un 50%
remission.
de
That
los
is how
pacientes
many
que recibieron
patients
inicialmente la
remain
insulina.
normal
El
glycemic. At
estudio
the
lo
end of year
replicaron en
1,
otros estudios en
patients
Asia
were on
y
insulin
básicamente lo
were
que ven
more
es
likely to be
lo
in
que
remission
mejora es la
compared to
secreción
those who
aguda de
were on
insulina.
oral
Entonces,
drugs. That is
al poner
almost
la célula beta
50% of
en
the
reposo
patients
con
who
la que les ven
initially
con insulina,
received insulin.
luego recupera
They
más
replicated
fácilmente
the study
esa
in other
secreción
studies
aguda de insulina.
initially,
Y
and
los metaanálisis
basically
lo que
what they
indican es lo
see is what
siguiente. En ese
improves is
estudio,
acute
la tasa de
insulin
remisión en
secretion.
promedio al
By
año
putting the
es
beta cell
aproximadamente
at
un
rest with insulin
50%,
therapy,
con la
then it
limitante de
recovers
que
more
todos
easily
estos
than
estudios
acute
han
insulin
sido realizados
secretion.
en Asia.
And the meta-analysis indicate
Luego,
that in different studies,
tenemos
the
diferentes
average
estrategias
remission
para
rate at
alcanzar las
1 year
metas
is
de
approximately
tratamiento o
50% with the
en pacientes con
limitation
diabetes
that
tipo 2.
these studies
Entonces,
have been
uno
conducted
primero,
in
digamos, un
Asia.
nuevo cambio en
Then
el
we have
paradigma es,
different strategies
cuando
to
nosotros
achieve
vemos que
treatment
un
goals in
paciente
a
con
patient
hemoglobina
with type 2
glucosilada alta,
diabetes.
que está
So
utilizando agentes
first, a
orales,
new
¿quién es el
paradigm shift
responsable?
when we
Entonces,
see a
antes se
patient
decía
with
que
a
entre
high
más cercano a la
glycated
normalidad, entre más
hemoglobin,
cercano al
which
7,
is
la
using
hemoglobina
oral
glucosilada,
agents, who
las
is
glucemias
responsible
postprandiales
then?
podían tener un
Previously, it
mayor
was said
efecto.
that the
Sin
closer to
embargo, este
normal,
estudio lo que
the
demuestra es que en
closer
pacientes
to
utilizando agentes
glycated
orales, cuando
hemoglobin
cursan
of
con
7
hiperglicemia, el
postprandial glycemia
80% de la
could have a
responsabilidad de
greater
la
effect.
hiperglicemia
However, what the
es
study
la
shows
insulina,
is
es la
that in
glicemia en
patients
ayunas, la
using
hiperglicemia
oral
basal.
agents when they have
Entonces, vean cómo
hyperglycemia,
las hiperglicemias
80% of the
postprandiales
responsibility
corresponden más o
for the
menos al
hyperglycemia
20%
is
únicamente,
fasting glycemia,
independientemente de
basal
la hemoglobina glicosilada que
hyperglycemia.
está el paciente.
See how postprandial
Entonces,
hyperglycemia
básicamente el concepto
corresponds
aquí es,
to
si
more
el
or less
paciente amanece
20%
alto, si está
only,
amaneciendo en
regardless of the
200, cuando
glycated
come va a
hemoglobin.
subir a
Basically,
300
the
y
concept
pretender
here
que los
is that if the
agentes
patient
orales
wakes
los
up in the
bajen
morning
va
with
a
a
ser muy
high blood
difícil.
glucose
Entonces,
pressure, if he
con la
is
insulina basal,
waking
lo
up
que
with
hacemos es que en
200,
lugar
when
de
he
arrancar en
eats, he's
200,
going
que
to go
arranquen
up
en
to
100,
300, and it
entonces
is
los
going to be
picos
very
postprandiales
difficult
no va a
to
llegar como a
expect oral
160,
agents to bring
180,
it
y
down.
ahí sí es
With
más
basal
factible
insulin, what we
que
do
los
is that
agentes
instead of
orales
starting at
empiecen
200,
a
we
los pueda
start at
controlar.
100, and then the postprandial
Entonces,
peaks will
básicamente
reach
lo que estamos haciendo es
160,
básico. Entonces,
180, and
el
then it
primer
is
consejo aquí en la
feasible for me
insulinización con
to
diabetes tipo
control
2,
them
cuando
with
les
oral
empezamos una
agents.
insulina basal,
Basically,
es
the first
no
tip here in
quitemos
the
los agentes
initiation with
orales,
type 2
porque los agentes
diabetes,
orales
when we start a
inevitablemente
basal insulin,
manejar
is
esas glicemias
don't take
postprandiales.
away the oral
Y esto está
agents,
demostrado
because
en
the
este
oral
estudio.
agents
Entonces,
allow
a
you
un
to
grupo,
manage
cuando
these
inició insulina
postprandial
basal, les continuaron
hyperglycemias.
los orales
And
y al
that
otro
is
grupo les
demonstrated in this
descontinuaron los
study.
orales.
So one
Y
group,
vemos
when
cómo la
they
hemoglobina
started
glicosilada
basal
bajó más
insulin,
en aquellos
they
pacientes que
continued with
continuaron los
oral
orales
agents,
y
and
la
the other
cantidad de
group
insulina que
discontinued the
requieren
oral
es menor
agents. See
comparado
how
con
the
aquellos que
glycated
descontinuaron
hemoglobin
los orales.
decreased
Entonces,
more in those
no hay por
patients
qué
who
suspender
continued
los
the
agentes
oral
orales
agents, and
una
the
vez que
amount of
nosotros iniciamos
insulin
insulina.
they required
Lo
was
segundo
less
es
compared to those
titulación.
who
Pues estamos
continued the
acostumbrados a
orals.
utilizar
There is no
10
reason
unidades
to
al día de insulina
discontinue
basal,
oral
pero el error
agents
es
once
muchas
we
veces quedarnos con
initiate
esas 10
insulin. The
unidades.
second
Entonces,
thing is
hay que
titration.
titular
We
hasta
are used to
alcanzar las metas
using
de la
10
glicemia
units a day
diaria.
of
Y
basal
esto se
insulin,
demostró en
but the
este estudio,
mistake is often
donde
to stay
si
with those
nosotros
10
titulamos a
units.
una glicemia
So we have
normalizada
to
más
titrate
agresivo, por
until we
ejemplo,
reach the
entonces si le
fasting
titulamos a una
glycemia
glicemia
goal.
cercana entre
And that
70
has
y
been
90,
demonstrated in
vemos
this
que
study.
como
If
la
we
reducción de
titrate to a
hemoglobina
more
glicosilada
aggressive
es
fasting
mayor
blood sugar,
comparado
for
con
example,
titular a
if
una
we
glicosilada
titrate to
entre
a
80 y
glycemia close to
110.
between
Entonces, si yo quiero
70 and 90,
tener una meta
see
más
how
estricta de
the
1C,
reduction in
probablemente
glycated
tengo que ser más
hemoglobin
estricto
is
con la
greater
glicemia en ayunas
compared to titrating to
a la
a
cual yo
glycemia
quiero
between 80 and
titular.
110.
Lo
So if we
tercero
have
aquí,
to be a
entonces,
stricter A1C
luego,
goal, I
entonces,
probably
mucho de
have
la
to be
falla está
stricter
en la
with the fasting
titulación. Entonces,
glycemia,
vemos cómo
which
la
I
reducción
want
de
to
la hemoglobina
titrate to.
glicosilada a través del
Third, a
tiempo
lot of
con
the
insulinas
failure is
basales,
in the
la mayor
titration.
parte lo
So
vamos a
we
lograr en los primeros
see how
3 a
the
6
reduction
meses.
of
Y lo que
glycated
ya luego yo
hemoglobin
utilizo en
over
6
time with
meses es muy
basal
difícil de bajar
insulin, we're going to achieve
posteriormente.
most
¿Por
of
qué?
it
Porque ya
in the
luego
first three to
fallamos en la
6 months.
titulación.
And
Entonces,
what we did
tenemos que
not
estar
reduce
titulando
at
aquí
6 months is very
rápidamente
difficult to
para
lower lower later.
hacer el tratamiento.
Why? Because we then
¿Y
fail to
cuánto es lo que
titrate.
necesitamos de
So
insulina
we have
basal?
to be
Entonces, el tercer
titrating
consejo,
quickly to reach the treatment
no nos
goals. And how
excedamos
much
en la
basal
basalización.
insulin do we need?
Entonces, este meta-análisis nos indica que la dosis
So the
promedio de
third
insulina
tip is
basal en
let's not
general es de
over-titrate. This
aproximadamente
meta-analysis tells
0.48 unidades
us
por
about
kilo. O
the
sea, en números
average basal
redondos,
insulin dosage
0.5.
in general is
Entonces, en un
about
adulto que pesa 80 kilos,
0.48
hay
units
que
per
llegar
kilo.
alrededor de
So in round
40
numbers,
unidades de insulina al
0.5.
día. Y
If
vea que
an
estamos hablando de
adult
empezar
weighing
con
80
10,
kilos, it is
pero la dosis
necessary to
promedio
reach
que se
about
requiere
40
es hasta
units of
40
insulin per
unidades
day. We are
diarias.
still
Entonces,
talking
por
about
eso es
starting with
importante
10,
considerar.
but the average
Pero un
dose
error muy
required
común
is up
es
to
seguir
40
aumentando
units
la
per
dosis de
day. So
insulina
it is
basal
important to
y ya no
titrate.
ganamos nada
But
del
a
estudio.
very important
Entonces,
mistake is
este
to
estudio es
keep
interesante
increasing
por
the
eso.
basal
Este estudio toma
insulin dose,
pacientes que
and we
están
don't gain
utilizando
anything
menos de
from it. This is why
0.5
this study
comparado
is
contra los que están
interesting.
utilizando
It
más de
takes students
0.5 de insulina
patients
basal
who are
y
using
vean
less
cómo la
than
reducción de
zero point
A1C
0.5
es
compared
igual.
to those who
Y
are
si
using
utilizamos un
more
punto
than
corte
0.5 of
0.7,
basal
igual
insulin,
y un
and we
punto de
see
corte
how
de
the
1,
reduction in
incluso
1C
los que
is the
estaban
same.
utilizando
And if
más de
we
1
use a
gramo
cutoff point
por
of
kilo, no
0.7
reducen
or a
tanto los
cutoff
niveles de
point of
glicosilada.
1,
Y
even those who are
lo que va
using
a
more than
pasar
1 unit
es que
per
si
kilo
empezamos a
don't
utilizar
reduce
más dosis
their
de la planta de la
glycosylated
insulina, no solo ya no ganamos más en
hemoglobin that
reducción de
much. And what is going
homoglobicidad,
to happen
sino que el
is that
precio a
if
pagar
we
es que
start
empezamos a
using more
aumentar mucho
doses of
más el
insulin
riesgo
than
de
the insulin
glicemias.
count,
Entonces, si no
not
alcanzamos la
only do
meta
we
con
no longer gain
0.5 unidades por
more
kilo,
in
hay que ver qué es lo que está
glycosylated
sucediendo y probablemente es hora
hemoglobin
de agregar
reduction,
una
but the
insulina de
price
acción
to
rápida,
pay
empezar a
is
agregar
that we
dosis.
start to increase the
Y
risk
ese
of
es el
hypoglycemia much
siguiente
more.
consejo aquí es,
So if
de las
we don't
insulinas
reach the
basales que
goal with
nosotros
zero
tenemos
point
hoy en
0.5
día,
units per
de los
kilogram,
análogos,
you have to
¿cuál
look at
escogemos?
what's
Entonces,
going on.
yo creo que el
And it's
primer consejo
probably
aquí
time
es,
to add
use
a
la insulina
rapid
que tengan a
acting
mano.
insulin.
Entonces, es una
Start
realidad
adding
en
boluses.
América
That's the
Latina
next tip.
que la parte
Of the
económica es
basal
una limitación.
insulins
Entonces, si
that
yo
we have
trabajo a nivel
today, of the
institucional y lo que
analogs,
tengo es
which one do
NPH,
we choose then?
insulinicemos con
I think the
NPH,
first
no
advice
manipulemos.
here is
Pero si
use
yo
the
puedo
insulin that
escoger
you
y
have
el
at
paciente
hand.
lo
It
puede
is a
costear,
reality
entonces
in Latin
la
America
quina
that the
comparado con
omic
NPH, ya
aspect is
vimos en
a
el Fit to
limiting
Target,
factor. So if
produce
we
menos
work at the
hipoglucemias.
institutional level,
¿Y qué pasa
and
con las
what I
insulinas
have
más
is
buenas? ¿Qué
NP
pasa con
insulin with
degludec y
NPH,
glargina
there is no
U300?
problem, but I
Pues
can
resulta que hay
choose
dos estudios
and
comparativos
but if I
directos
can
entre
choose
sí.
and the patient can
Entonces,
afford it, then
glargina
Glardina
U300,
compared
este
to
estudio, el estudio
NPH. As
PRIME,
we
es
know,
patrocinado por la
as we
compañía
saw,
que
the
produce
treat to
glargina
target produces
U300,
less
que es Sanofi.
hypoglycemia.
Y
And what about
comparado
the
contra
more modern
degludec, en el
insulins?
estudio
What
PRIME,
about
mostró que
Degludec and
glargina
Glardina
U300
U300?
produce
So it
un
turns
poco
out
menos de
that there are
hipoglucemias en la
two
fase de
different
titulación.
comparative studies with
Por
each
el
other.
otro
So
lado, ¿verdad?
Glargine
Tenemos el
U300, that
estudio
study,
Conclude.
the BRIGHT study,
Esto
is
es
sponsored
patrocinado
by
por
the
la
company that
compañía que
produces
produce
Glardine
degludec, que es Novo
U300,
Nordisk.
which is
Y en el
Sanofi,
Conclude
and
vieron que
compared
más
against
bien que el
Degludec in the
degludec
BRIGHT study.
producía un
It
poco
showed that
menos de
Glardine
hipoglucemias aquí, ¿verdad?
U300
En el
produces
periodo de
slightly less
mantenimiento
hypoglycemias
comparado
in that
contra glargina.
glycation
O
phase.
sea, el estudio
On the other hand,
patrocinado
we have the
por
Conclude
glargina
study. This is
mostró que
sponsored by
glargina
the
producía
company
menos
that
hipoglucemias.
produces
El estudio
Degludec, which is
patrocinado por
Novo
degludec
Nordisk.
mostró que
And in
degludec producía
Conclude,
menos
they saw that
hipoglucemias. Mi
Degludec
conclusión de
produced
esto es que son
slightly less
insulinas
hypoglycemia here
muy,
in the
muy,
maintenance
muy
period
similares,
compared
¿verdad?
with
Entonces,
Glardine
realmente la
U300.
diferencia entre
The
100
study
tasas de
sponsored by
hipoglicemias
Glardine
es
showed that
muy bajo
Glardine
y
produced
utilicemos el que
less
tengamos a mano.
hypoglycemia, and the study sponsored
Ok.
by Degludec
Y
showed
si el
that
paciente
Degludec
entonces no llega a
produced
la meta
less
con 0.5
hypoglycemia.
unidades
My
por kilo de
conclusion
insulina
here
basal, el
is that
siguiente
they are
paso
very,
entonces es
very
agregar
similar
insulina
insulins, right?
prandial.
So
No
really,
estamos
the
hablando hoy de
difference
otras
between
estrategias como
hypoglycemia
agregarle
rates is very low.
GLP-1
And
o
let's
agregar
use the one we have at hand.
inhibidores
And if the
sino que nos
patient then
estamos
doesn't
centrando
reach the
únicamente en
goal with
insulinas.
0.5
Entonces en
units
insulinado,
per
entonces
kilo
lo
of
que
basal
corresponde es
insulin,
agregar
the next step
insulinas
then
de
is
acción
to add
rápida.
prandial
Y
insulin. We
aquí
are
también
not
un
talking
paradigma
today
clásico
about
era
other
cuando necesitamos
strategies
agregar
like
insulinas de
adding
acción rápida,
GLP-1s or
empezábamos de una vez con
SGLT2
3
inhibitors.
bolos.
We are
Y eso no
focusing only
necesariamente es
on
cierto.
insulin. So
Este
what is
estudio,
appropriate is
el
to
estudio
add
4G,
rapid
mostró
acting
que
insulins. A
después del
classic
primer año,
paradigm was when
la
we need to
mayoría de los
add rapid
pacientes,
acting
empecemos
insulins.
como
We
empecemos.
would
Si
start
empezamos
at
con
once
bifásicas,
with
con
3 boluses,
premezclas,
and
si
that's not
empezamos con
necessarily
insulina
the
basal
case.
como
This
DTB
study, the
o
4T
insulina o
study, showed
empezamos con
that after
insulinas
the
de acción
first year,
rápida,
most
después
patients,
del primer año,
regardless of how we
más del
start, if
70%
we
de los
start with
pacientes necesitamos
biphasics with
intensificar. Es
premixes,
decir,
if we
que
start with
aquel que
basal
empezamos con insulina
insulin, such as
basal,
Dedamer,
vamos
rapid
a tener
acting
que agregar
insulins after the
entonces
first
insulinas
year,
de acción
more
rápida.
than
Y los que
70% of
empezamos con
patients need
rápidas
to
hay que agregarle
intensify their
basal y
treatment.
los que
That is,
estaban
those
con
who start
premezcla hay
with
que
a
agregarle
basal
una tercera
insulin,
dosis
we
de la
will have to
premezcla.
add rapid
Entonces
acting
hay que
insulins,
intensificar
and
en el
those who
tratamiento.
started with rapid
¿Ok?
acting insulins
Este
will
estudio
have
a mí
to add
personalmente me
basal, and
gusta
those
mucho
who
porque
were
lo
on
que hace es
premixes
comparar
will
dos
have to add a
estrategias de
third dose of the
intensificación.
premix.
Entonces,
So we have to
uno es
intensify the study.
decirle al
I
paciente
personally like that
en qué
study
momento
very
del día es
much
que usted come más
because what
carbohidratos
it
y
does
en
is to
ese
compare
momento
two
se le agrega la primera
intensification
dosis de insulina de
strategies.
acción rápida.
Number one is to ask the patient
Comparado con
when,
una
at
estrategia
what
que es
time of the
inhibir
day
glicemias,
you eat the
ver en qué
most
momento del día tienen
carbohydrates,
la
and at
mayor
that time you
hiperglicemia
add the
y ahí
first dose
agregar
of
la primera
rapid
dosis de
acting
insulina de acción
insulin.
rápida.
Compared
Si
to a
después de 2
strategy that is
semanas
to
no llegaban
measure
a la meta,
glycemias
se
to
vuelve
see
a
at
hacer el
what time
ejercicio
of the
para
day
agregar
they
el
have the
segundo bolo de
highest
insulina.
hyperglycemia,
¿Y
and
qué
then
fue lo que
add the
mostró?
first dose of
Entonces,
rapid action
el primer
insulin.
bolo de insulina
If
reduce
after 12
aproximadamente
weeks they did not reach
0.5
the goal, the
unidades,
exercise was done again again to add the second bolus of insulin. And what did the first bolus of insulin show? It reduces approximately 0.5 of glycated hemoglobin. And this is independent outside of the strategy. So a very simple way is to ask the patient at what time of the day do you eat the most carbohydrates, and we start bolusing 0.1 units per kilogram of the rapid acting insulin. So if it's Lispro and the patient weighs 80 kilos, 8 units before lunch, for example, and that's it. The second bolus of insulin reduces around 0.5 approximately of the glycated hemoglobin. And what we gain with a third bolus of insulin really is very little. And the other study, full step, what it compares then is the sequential intensification compared to a full basal bolus. And what did they do? In the full basal bolus, what they did was they added at one time 2 units of aspart insulin with each meal, and in the sequential, they added 4 units of aspart with the largest carbohydrate meal. And if after 11
Por
weeks, they
supuesto, los
didn't
que
reach the
empezaron con
target.
3 bolos de
They
insulina
added one
bajaron a la
second bolus,
glucosilada
and if
rápidamente.
after week
Pero cuando
22, they
nosotros
didn't
vemos a
reach the
las
target,
32
they
semanas,
added
la
in
reducción
the
de hemoglobina
third
glicosilada
bolus.
fue muy
And what
similar.
did they see?
Y
Since
la otra
those who
ventaja
started
es
with
que
the
el
three
porcentaje
single
de
boluses,
pacientes
the
cancelando
glycated
seguramente al menos de
hemoglobin
7% de
dropped
hemoglobina
rapidly.
glicosilada
But
no
when
hubo
we
una
look at
diferencia
32
significativa,
weeks, the
que es lo que
reduction
es
in
lo
glycated
significativo.
hemoglobin was
Pero un
very
dato muy
similar.
interesante aquí es
The other
que aquellos
advantage
que
is that the
utilizaron bolo
percentage of
secuencial, a pesar de
patients
tener una
who
hemoglobina
reached goal
glicosilada
at least
similar,
7%
17% de
glycated
los pacientes
hemoglobin,
llegaron
there
a la
was
meta
no
con solo
significant
un
difference.
bolo,
So see that the P
27%
is not
requirieron 2
significant. A
bolos,
very
es decir,
interesting fact here is that those who
45% de los
use sequential
pacientes
bolus,
no requirieron un
despite
tercer
having
bolo
a
de insulina,
similar
¿verdad?
glycated
Y la
insulin,
cantidad de insulina de acción rápida que
17% of the
requirieron
students
es
reached
muy
the
similar
target with
en
only
promedio
one
al que
bolus.
utilizó el basal bolo
27%
completo.
required two
Por eso es que
boluses.
hoy en día
That
algunos
is,
pues
45% of the
empezamos a
patients
poner
did not
bolos
require a third
secuenciales,
bolus
ya no
of
utilizamos el
insulin,
basal
right?
bolo
And the
completo
amount of
de un
rapid
inicio,
acting
porque
insulin
no
they
todos los
required is
pacientes
very
requieren
similar
3
on
bolos de
average
insulina.
to the full
Y lo
basal
otro aquí
bolus.
es que
We
si
no
nosotros
longer
comparamos
use
la
a
tasa
full
de
basal
hipoglucemia,
bolus from the
vemos
beginning
cómo
because
los
not
bolos
all patients
secuenciales, además de ser
require
más
three
sencillos para el
boluses
paciente y
of
más
insulin.
cómodos,
And the other
entonces
thing here
producen
is that
menos
if we
hipoglucemia
compare the
comparado con aquellos
hypoglycemia
pacientes
rate,
que utilizaron
we
un
see how
basal bolo
sequential
completo.
boluses, besides being easier
Entonces,
for the
ese es
patient
el
and more
estatus que tenemos
comfortable,
hoy en día.
then
Entonces,
they
en
produce less
resumen,
hypoglycemia compared to
en la
those
forma en que nosotros
patients who
insulinizamos
use
hoy
a
en
full
día,
basal
es
bolus.
empezar primero con un
So that is
basal,
the status we have
dejando
today.
los
In
agentes
summary, the
orales,
way
y si el
we
paciente
use
falla
insulin
con los
today is
orales,
to
perdón,
start with
falla
a
con el
basal
basal,
first,
llegando a
leaving the oral
0.5 unidades por
agents,
kilo
and
más
if
o
the
menos,
patient
es hora
fails
de
with the
ir
basal
agregando
getting to
bolos y la
zero point
estrategia
0.5
se llama bolo
units per
secuencial.
kilo, so it
¿Qué
is
nos
time
depara
to
el
add
futuro con la
boluses,
insulina?
and the
Y esto está a la vuelta
strategy
de la esquina.
will be
Entonces,
sequential
hay una insulina de
boluses.
acción
What
semanal.
does the future
Ojo,
hold
semanal,
for
eso se llama
insulin?
insulina
And
ICODEC.
this is just around the
ICODEC lo
corner.
que hace
Well,
es
there is
agregarle
a
un
weekly
aminoácido,
acting
perdón,
insulin. This
un
is called
ácido graso de cadena
icodec
larga aquí.
insulin.
Entonces,
Icodec acts a
que este
long
ácido graso lo
chain
que
fatty
permite es
acid
tener mayor
here. So
afinidad por la
what this
albúmina.
fatty acid
Entonces, tanto en el
does
espacio
is
subcutáneo como en la
it
circulación,
allows it to
se
have
liga a
a
la albúmina.
higher affinity for
Entonces, esto
albumin.
prolonga y
So
forma como un
both in the
depósito y prolonga
subcutaneous
su acción.
space and in the
Entonces, esto
circulation, it
permite
binds to
administrarlo una vez a la
albumin.
semana.
This prolongs
Entonces,
and forms a
ya que
deposit
la
and
vida
prolongs
media,
its
entonces en
action, so
humanos
it
es
allows
alrededor
it
de
to
ciento
administered
seis
once a
horas
week.
la vida
See,
media.
the
De acuerdo que
halftime then in
requerimos 4
humans
a
is
5 días
about
menos para eliminar
196
más del
hours. The
95% del fallo.
halftime according to what we
Entonces,
require,
el estudio clínico
four to five
pues,
halftimes to
el
eliminate
programa de ensayos
more
clínicos
than
con ICODEC se llama los
95% of the
estudios
drug.
ONWARD.
The
Pues
clinical
acuérdense que yo les
study
mencionaba al
program with
principio que
ICODEC
una unidad de
is called
insulina es igual
Onward
si es
Study. So
una unidad
remember
de
that I mentioned at
prolactina
the
o una
beginning
unidad de
that
NPH.
a
Por eso es que
unit of
cuando se
insulin
titulan
is the
llegan a la
same
misma
whether it
hemoglobina
is a unit
glicosilada.
of our
Entonces, porque usan
glargine
la
or
misma
a
cantidad de
unit
insulina
of
llegando a la misma
ANPH.
meta
That
de
is why
glucemia
then
glucosilada.
they are
Pero este dato muy
titrated. They
interesante
reach
con
the
ICODEC.
same
Vean cómo compara
glycated
ICODEC, por ejemplo,
hemoglobin.
contra
So why
glargine.
do they
Entonces,
use
en
the
diferentes
same amount
estudios.
of
Este es
insulin,
ONWARDS
reaching
1,
the
¿verdad?
same
Esto es
fasting
ONWARDS
glycemia goal?
4 y los
But this is
diferentes
very
formulas.
interesting
Y
data
vean
with
cómo que
ICODEC. See
en
how they
muchos de estos,
compare
a
ICODEC,
pesar de
for
llegar a la
example,
misma
versus
glicemia
glargine then
metabólica,
in different
por
studies,
primera vez
Onward
tenemos
1. Now
superioridad de una
that's
insulina
Onwards
comparada
4
con
and the
otra.
different
Entonces,
onwards,
aquí
and
se
see
redujo
how
más la hemoglobina
it
glicosilada con
kind of
ICODEC
fits in
comparado
many of
con las
these
otras,
despite
con los
getting to
comparadores
the
tanto
same fasting
degludec
glycemia
como con
for the first
glargine.
time. See how
Entonces,
you see the
y si es una insulina de
non-superiority of
acción
one
temporal
insulin
una vez a la
compared to
semana, ¿qué
another.
pasa
So
con el riesgo de
here was
hipoglucemia?
more reduction in
Entonces, esto es
glycated
tiempo en
hemoglobin
rango
with
y podemos ver
icodec
que la mayoría
compared
de los
to the other
pacientes donde produce
comparators
más
for
hemoglobina
degludec
glicosilada con
and
ICODEC, el
glargine.
tiempo de rango
So
es
what if
mayor,
it's a
pero ya que la
long-acting
tasa de
insulin
hipoglucemia
as
usualmente
long
es
as
muy
once a
baja
week?
y
But
es comparable
what
al
about the
placebo.
risk of
Ese es el porcentaje
hypoglycemia?
de
This is
pacientes que
time in
alcanzan
range,
metas.
and we can
Por
see that
supuesto, si
most of the
baja más la
patients,
hemoglobina
when
glicosilada,
it
el
reduces
porcentaje de
their
pacientes que alcanzan metas va a
glycated
ser menor.
hemoglobin more than
Y un
icodec,
dato muy
time and
interesante
range and
aquí, entonces,
higher.
es la
But
tasa
see
de
that the rate of
hipoglucemias. Entonces, aquí
hypoglycemia is
ligeramente,
really is
¿verdad?
very
Aumenta,
low
esto es
and it's
menos de
comparable to
72.
each other.
Entonces,
That's a percentage
ligeramente
of
más con
patients who reach
ICODEC de lo
goals.
que hay con
Of course, if
glargina.
you lower the
Hipoglucemias
glycated
severas,
hemoglobin, the
no una
percentage
diferencia
of patients
significativa.
reaching goals
En el mundo de los
is going to
sensores,
be
hoy en día
higher. A
instalamos
very
estudios con
important data
sensores.
here then is the rate
Esto
of
es
hypoglycemia.
hipoglicemias
So
con
there are
menos de
some
70,
slight
con
ones
más de
here, right?
15, con
A
menos
alert is
minutos.
less than
Y esto es
72,
menos
so
de
slightly more
70,
than
¿verdad?
icodec, than the
Menos de
insulin
70
glargine.
con menos
Severe
de 15 minutos en menos
hypoglycemias,
de
there is no
54.
significant
Y esto es
difference.
con
In the
más de
world of
15 minutos
sensors
en menos de
today, they did
54.
some studies with
Entonces, cuando se
sensors,
compara
that is
iCodec contra degludec,
hypoglycemia for
muy
less than
parecidos,
70
¿verdad?
for less than
Entonces,
15
y
minutes,
iCodec
and
contra
this is
glargina
less than
también
70
muy
with
similar.
less than
Entonces,
15 minutes
obtener
in
vida
less than
media más larga
54, and
no
this is
implica
with
que la
more than
hipoglicemia va a
15
tener mayor
minutes in less
duración.
than 54. So when we compare
Entonces,
icodec
en
versus
resumen, con
degludec,
iCodec,
very similar,
la
right?
eficacia es comparable con las
And
insulinas
icodec
basales diarias, sino
versus
es que hay
glargine
incluso
also
un
very
poquito más
similar because it
de
has a
reducción de
longer
A1C. La duración
half-life.
de hipoglicemia es similar.
The
Lo que nos va a cambiar
efficacy
el
is
paradigma
comparable
es
with
la
daily Bailey
titulación. Entonces,
insulin
nosotros
if
veníamos
we,
acostumbrados a titular
if not even a
3
little bit
unidades al
more
día con las
reduction of
basales. Como
A1C.
es
The
semanal, esto hay
hypoglycemic
que
duration
titularlo
is
por
similar, which
semana.
is going to
Entonces,
change
son
the
3
titration
unidades al
paradigm.
día
So
Entonces,
we were
3 por
used
7,
to
¿verdad?
titrating 3
21.
units per
Lo que
day
se
with
hace es
basal
titular
as
20
it is
unidades
weekly. This
cada
has to
semana.
be
Y
titrated
cuando
weekly.
vamos a
So
iniciar,
if
en
it
lugar de
is
iniciar 10
3
unidades
units a
diarias,
day,
empezamos
then
70
3
unidades a la semana.
times
Entonces,
7 is
todo lo que
21. So
estamos
what we do is
acostumbrados a hacer los
titrate
cálculos
20
con la
units
insulina
each
diaria,
week. And when we
multiplíquenlo
are
por
going to
7.
start,
Y
instead
eso
of
es todo.
starting 10
Como
units
tiene
a
una
day, we
duración de
start
acción tan
70
prolongada,
units a week.
va a durar
Everything that
mucho
we are
tiempo en
used to doing
alcanzar
the
el estado
calculations with the
gestacional.
daily
Entonces, si
insulin,
hacemos un switch,
multiply it
el
by
paciente adquiere
7,
una
and
dosis de
that's it.
carga para alcanzar
Because it has
el estado
such a long
estacionario más
duration of
rápido.
action,
Esta
it's going
dosis
to
de
take a
carga
long
es de un
time to reach a
50% de la
steady
dosis.
state. So if we do a
Y desde el
switch
punto de
here,
vista
the
de
loading dose
volumen, no hay ningún
to
problema
reach a
porque
steady
esto
state
es un
faster,
700.
and
Entonces,
this
la
loading
cantidad de
dose is
volumen no es del todo
50% of the
problema.
dose. From the
Les
volume point of
mencionaba que
view,
hay
there's no problem because this
esto
is
ya está aprobado en muchos
U700,
lugares
and the
del mundo.
amount of volume
Entonces,
is not quite
recientemente,
as
vean, el
high.
11 de julio,
This
hace
is
apenas una
already
semana,
approved in some places
entonces
in the
la
world.
FDA,
Recently,
entonces
on July
no
11,
aprobó
just
el
a week
ICODEC
ago, the
comparado
FDA
con
did
Glargina.
not
No
approve
aprobó el ICODEC
ICODEC
para venta en Estados Unidos
compared
para
to
diabetes tipo 1,
glargine. They did not
porque a
approve
pesar de que
ICODEC for
muestra una
sale in the
eficacia
United
similar a la
States for
glargina,
type
tuvo
1
mayor tasa de
diabetes because
glucemias en
even
ese
though it
estudio.
demonstrated
No han
similar
evaluado los
efficacy
estudios en diabetes
as
tipo 2 todavía.
glargine, it had
Sin
higher
embargo, con los
rates of
mismos datos, la
hypoglycemias in this
Agencia
study.
Europea de
They
Medicamentos,
have not
EMA, ya
evaluated
lo
studies in
aprobó.
type 2
También ya está
diabetes
aprobado en
yet.
Canadá,
However, with the
Australia,
same data,
Japón y
the
Suiza, tanto
European
para diabetes
Medicine
tipo 1 como
Agency,
diabetes
EMA,
tipo
has
2.
already
Y ya en
approved it.
China
It
está
is
aprobado
also
para diabetes
tested in
tipo 2.
Canada,
Entonces,
Australia,
lo más
Japan, and
cercano que tenemos es
Switzerland for
Canadá
both
y
type
este es
1
el
and
nombre
type 2
comercial de
diabetes.
ICODE.
And already in China, it is
Les
approved for
mencionaba
type
que
2
hay un segundo que
diabetes.
es
The closest
Epsitora.
we have is
Epsitora lo que hace es
Canada,
tomar
and
una
this is
molécula
the
de
trade
insulina
name of
y lo
ICODEC.
pega, ¿verdad?
I
Lo
was
fusiona
mentioning
con
that
una
there is a second one,
IgG2-1,
which
¿verdad?
is
En el amino FC.
F-Soda.
Esto
F-Soda
va un
takes
poquito
an
más
insulin
atrás. Lo que han salido son
molecule
los estudios
and
fase
it
2.
glues it. It
Entonces,
fuses
los
it with
estudios
a
fase 2
human
cuando se compara,
IgG2 of
entonces
the
es
FC
inicialmente se
domain.
llama basal
This
insulin
goes a little bit further
FC.
back. What
Entonces,
has
este es
come out is
el
phase
nombre
2
químico
studies.
sería
So phase
Epsitora
2
en
studies,
beef.
when it is
Comparado
compared, then
con
it is
claritide-glued,
initially
pues
called
vemos
basal
cómo la
insulin
eficacia
NFC.
en reducción de
The
glucosa es
chemical
muy
name
similar,
would be
tiempos en
BIF
rango
if
muy
soda
parecido,
compared
entonces no
to
es muy diferente.
glugludec. We see
Desde el
how
punto
the
de vista
glucose lowering efficacy is
hemoglobina
very
glicosilada
similar,
similar,
very
glicemia
similar
en ayunas
time and
similar,
range. So
y el
it is
riesgo de
not
hipoglicemia
very
nuevamente
different from the
no es
point of view
diferente
of
comparado
similar
con, no es
glycated
estadísticamente significativo,
hemoglobin,
aunque
similar fasting
numéricamente un poquito
glycemia,
más
and the
con
risk of
Epsitora comparado contra
hypoglycemia again
Degludec
is not different,
en
not
este caso, ¿verdad?
statistically
Pero vean que los
significant,
intervalos de
although
confianza crecen en el
numerically a
grupo y
little
por lo
bit
tanto no
more
es
with
estadísticamente significativo.
F-Citora compared to
Entonces,
degludec in
en
this case.
conclusión,
We see that the
en este
confidence
listado que hemos dado
intervals
por la
cross
historia,
1, and
pasamos de
therefore it is
inyectar
not
1 o 2 veces
statistically
al día la insulina
significant.
para evitar
In
síntomas
conclusion,
a
in
tratar
this
de
glimpse
alcanzar las
that we've
glicemias lo
taken
más
through
cercano a lo
history,
normal
we went
posible
from
con un riesgo
injecting
menor de hipoglucemia.
insulin 1 or 2 times
Los
a
análogos de
day
insulina
to
son más
avoid
convenientes y
symptoms
seguros.
to trying to
Para
achieving
personas que tienen diabetes
glycemias as
tipo
close to
2,
normal as
deberíamos empezar con
possible
una
with a
insulina
low risk
basal
of
y mantener
hypoglycemia.
agentes orales.
Insulin
Y si
analogs are
falla,
more
entonces
convenient and safer.
intensificamos con
More
bonos
people who have
secuenciales que
type
también se
2
conocen como
diabetes,
basal
we should
incluso.
start with a
¿Ok?
basal
Y las
insulin and
insulinas
Mantel
basales
or
semanales ya son
oral
una
agents. And
realidad
if that
y sobre
fails,
todo ICODEC
then
que ya
we
se está
intensify with
comercializando en algunos
sequential
países del mundo.
boluses, which are also known
Muchísimas
as
gracias por
basal
la
plus.
atención.
Thank
Vamos a
you very
terminar
much
con
for
nuestras
your
preguntas.
attention. We are
Aquí
going
están
to
mis
have a few
contactos y
minutes for
estamos a la orden.
questions.
Muchas
Here are my
gracias.
contacts, and we are at your disposal. Thank you very much. Well, good morning to all participants. Thank you for your participation. Thanks to Dr. Cheng for his excellent presentation, very didactic. Congratulations. We will now begin with a Q&A session. We have Dr. Gaipopiña from Ecuador asking regarding the insulin over basalization. What would be the adverse effects? Good morning, everyone. Thank you for joining this meeting to Dr. Chen. As we mentioned in our presentation, the problem with this is that usually if we see the studies that I presented, the point of cork is 0.5, then we do not achieve greater efficacy in glucose reduction. So glycated glucose is not reduced and we started having more hypoglycemia. So we start thinking, if I find 100, 120 according to the goal, I want lowering it to 70 or 80. Truly, the impact will not be that much. And we start having glycemias very close to the early morning. So it's not worthwhile than putting 0.5 units per kilo. But if the patient requires more than 0.5 units per kilo, let's see what happens. Either we don't include the insulin doses, the technique is not adequate, the dose is not adequate. It happens oftentimes that we don't see what happens to the glycemia during the rest of the day. So the patient is failing. and he has
Esa hiperglicemia la arrastra
hypoglycemia
toda la
after
madrugada
dinner,
y es lo que
then we
nosotros
will have it
reflejado en la
throughout
mañana
the
siguiente
night,
con una
and
glicemia
that
alta
is
en ayunas.
reflected in
Y
the
el error aquí
morning.
es
And the
meterle más
mistake
y más
here
y
is
más
to
basal
add
si no nos
more and
fijamos
more
en que viene
basil
arrastrando esa
if we are
glicemia
not
alta
aware
desde el
that he
postprandial
has
del
the
almuerzo o de la cena.
postprandial high
Entonces, solamente
glycemia from
0.5
dinner.
y por arriba
So
de
maybe it's
0.5 no ganamos en
0.5
eficacia y
and
vamos a tener más
probably
hipoglicemia.
0.5, we will not gain in efficacy and we will have more hypoglycemia. Any other
Buenos días a todos. Muchas gracias por
question?
la
Good morning,
participación.
everyone. Thank you
Una
very much
pregunta
for the
tal vez aquí
participation.
del chat.
I have another question
La
here in the
doctora Andrea
chat.
Peter de México, ¿cuál es el
Dr.
panorama de las
Andrea
insulinas
Peter from
prandiales
Mexico.
en la era del
What is
GLP-1?
the panorama in
Ok,
the era
no
of
tocamos
the
GLP-1s por el
GP1s?
tipo de tema
We did not
de la
address
presentación del día de hoy,
GP1s
pero
because
existen
of the
estudios comparativos
presentation we have
directos de
today, but
GLP-1
we have
contra insulinas. Entonces,
comparative
se ha comparado
studies
directamente
of
pacientes fallando agentes
GP
orales, GLP-1 versus
versus
insulina basal,
insulins
¿ok? Y muestran que
versus
son
basal
igual de
insulin, and they
eficaz, incluso
show
los
that
análogos de
they are
GLP-1, y
as
con menos riesgo de hipoglicemias
efficient
y
and
con
with
menos
less
aumento de
risk of
peso. Luego
hypoglycemia
también
and
existen estudios de
increase
pacientes que
in
están
weight. We
utilizando
also have
insulina basal,
studies of
agentes
patients
orales
that are
y que han
using
fallado. O sea
oral
que
agents
el
and
paradigma
basal
tradicional que
insulin and
que
are
hemos hablado,
failing.
en ese
So
contexto
the
es agregar
traditional
bolus de insulina
paradigm, as
rápida.
we've said, is
Y
to
aquí hemos
add
comparado también bolus de
fast
insulina rápida versus
insulin
análogos
boluses,
de GLP-1, incluso los de
and
acción
we
séptica.
have
Y
GPL-1,
el
those
resultado
that are
nuevamente
weekly,
es,
and the
es igual.
result,
Entonces,
once again, is the
GLP-1 son
same.
igual de
So
eficaces con la
GP-1
insulina,
are the
comparado con la
same as
insulina, sea la basal
have the
o las
same
prandiales,
efficacy
con
with
menos
the
riesgo de
prandial
hipoglicemia
with
y con menos
less
aumento de
risk of
peso. ¿Cuál es
hypoglycemia
el
and
problema con
less
esta estrategia?
risk
Primero es
of
acceso,
weight
primero es
gain.
costo, ¿verdad?
The
Entonces, no
first
todo el mundo
problem
puede
with
acceder a
this is
GLP-1s,
the
ni siquiera en los
strategy and
países
access
desarrollados.
and cost.
Realmente de
Not
todos los
everybody
pacientes
can
que
have
requieren
access
GLP-1s,
to it,
menos del 20% de los
even
pacientes a
less
nivel
from
mundial lo
the
están recibiendo en
underdeveloped
estos
countries.
momentos. ¿Ok? Entonces, esa es una primera
So
consideración.
this is
Y
a
dos,
first
a pesar de que
consideration I'd
muestra que
like
la
to make.
reducción de
And two,
glucosa
in
es
spite of the
igual,
fact
hay
that
que tener
the
cuidado desde el
reduction,
punto de vista
glucose
cómo está el paciente.
reduction
Es
is
decir,
the same, we
si yo
need
tengo
to
un
be
paciente que
careful
viene
regarding the
sintomático,
patient.
catabólico,
If a
poliuria,
patient is
polipsia, ¿verdad?
catabolic,
En ese caso, tal vez, a
symptomatic
pesar de que los
with
estudios del GLP-1 muestran que
polyuria
nos
and
reduce A1C
polypsia,
igual que
even if
insulina,
we
probablemente lo más
have
prudente es
studies that
empezarles con
show
insulina,
that
porque
the
es lo más
GP
rápido con lo que
is
vamos a revertir el
being
estado catabólico.
reduced.
Entonces,
So
hay que
we
tener
need
también
to move
un
on
poco de
more
cuidado.
quickly to
Pero sí, la
review the
respuesta
catabolic
corta es
state. We
el
need to be
primer
very
inyectable
careful
hoy en
because the
día, digamos, según
first
las guías a nivel
answer would
mundial,
be
las
the
guías son el
first
GLP-1
injectable
y
would be a
no las insulinas
GP-1
porque son
and
más
not
seguras.
insulins because they are safer.
Ok, tenemos otra pregunta
Okay,
aquí
we
de
have
la
another
doctora.
question from Dr.
Dice, ¿cuál es el panorama de las
What
insulinas en la era,
is
perdón,
the,
cuál es la
I'm
ventaja
sorry,
del
what is
tratamiento
the
de estos mellitus ante la aparición de
advantage
estos nuevos
of
hipoglicemiantes orales
the type
con
2
protección contra el
diabetes
síndrome
with
cardiorenal?
protection
Doctor Francisco
against the
Chizal de México.
what is the advantage
Ok,
now of the treatment
gracias
of
por la pregunta.
diabetes
Esto
mellitus
va
with the
muy en
appearance
relación
of
a la
these
pregunta
new
anterior
oral
también.
hypoglycemic
Entonces,
agents with
sí,
protection against
definitivamente el
cardiorenal
paciente
syndrome?
que se puede
Yes,
manejar
this is
sin insulina,
related to the previous
deberíamos priorizar
question.
los análogos
In
de
those
GLP-1 y
patients
los
that can
inhibidores
be
de
managed
SGLT2,
without
porque
insulin,
son los
we
agentes que
should
producen más pérdida de
prioritize the
peso,
analog
protección de órgano blanco, hablemos de protección a
GLP-1
nivel
analogs
aterosclerótico, entonces
and
cardiovascular, cerebrovascular,
cardiovascular
protección renal, ¿ok? Y protección contra
kidney
ataque cardíaco.
protection and
Sin embargo,
against
al igual
heart
como mencioné
failure.
hace un momento,
However, as
no
I
todos los
mentioned a while
pacientes
ago,
que
not
están con
all
estos agentes
patients
se
that
van a poder
using
sostener a
these
largo plazo en
agents
el
will
control,
be
¿verdad? Entonces,
sustained
muchos de estos
throughout
pacientes
time in their
requieren
control.
combinar.
Many of
Entonces,
these
yo puedo
patients
tener a alguien
require a
inicialmente utilizando un
combination.
GLP-1 con
So
una hipertensión de
initially, I
glucosa
can
y
have
después de un tiempo
an
tiene una
a
glicosilada alta.
GPL-1,
Entonces,
and
eso
after
no quiere
that,
decir que por estar utilizando
this doesn't
medicamentos que
mean
protegen
that if
órgano
they're
blanco, yo voy a
using
bajar hiperglicemia.
medications
Entonces,
that
este
use
paciente en muchas ocasiones
that
tengo
protect
que agregarle
their
otros fármacos,
organs, their
incluyendo
white
insulina basal.
organs, I need to
Entonces,
add
en relación a la
basal
pregunta anterior
insulin.
también,
So
si
regarding
yo
the
tengo a
previous
alguien que esté
question,
en
if
un
I have a
GLP-1, digamos,
patient who was
si en lugar de
offered a
empezarle una insulina basal, le
GPL-1, if
empecé un
instead of
GLP-1, pero
starting
después de un tiempo
with
el
basal
GLP-1 falla,
insulin,
yo siempre le puedo agregar
I
a eso
started
insulina
with a
basal. De
GPL-1,
hecho,
I can
acuérdese que
add basal
no lo
insulin.
tocamos en la
In
presentación,
fact,
pero
I didn't
existen dos
address it in my
formulaciones a
presentation,
nivel
but there are
mundial.
two
En México existe
formulations
la
worldwide.
coformulación y
In
nosotros
Mexico, we
en
have the two
Centroamérica contamos con solo
formulations.
una de
In
las
Central
formulaciones
America,
de
we
las
only have
mezclas
one
de
of them
preparación fija
of the
que viene
mixes of
GLP-1 con
fixed
insulina basal.
preparation where we
Entonces
have
mezclagina con lixisenatide
GPL-1
y
with
degluir con liraglutide precisamente para
basal
facilitar el
insulin. We
paso
have this
el
precisely to make it easier for the patient, because oftentimes they need to combine medications. They are complementary. They are not a competition. We need to normalize glycemia, not only protect the white organs. Remember, it's important to reduce their glycose. I have another question here from Maria Ramos. Thank you very much. Could this be
No hay
combined
ningún
with
problema. Entonces
insulin?
acuérdense que
Yes,
hablamos al
there's no
principio de la
problem.
importancia de
Remember
mantenerlos
that at the
orales.
beginning
Y es
we talked
justamente
about
que
the
si yo
importance of
tengo un
oral
paciente que está
agents.
con, viene, por
And
ejemplo,
if
con
I have a
metformina y una
patient, for
sulfonilurea,
example,
y
that
yo
is using
le voy a iniciar una insulina
metformina
basal,
and I will start
debería
with
mantener esa
basal
sulfonilurea.
insulin, I
¿Por qué?
should
Porque si yo le
maintain
quito la
the
sulfonilurea,
basal
va a amanecer
insulin,
bien
because
en
if
el
I
mes, pongámosle que
suppress
amanecen
their
100, 110
phenylurea,
días, entonces
they
con la
will
insulina que
have
le estoy poniendo,
110,
pero como
and
le
with the
quité la
insulin I'm
sulfonilurea,
adding,
no
but
tengo nada
since
que me
I
maneja la
retired
glucemia
the
postprandial. Entonces,
phenylurea, I
después
don't
del
have
desayuno
anything
me va a llegar a
that will manage the
180 más o menos por ahí.
postprandial
Va a
glycemia.
llegar al
So after
almuerzo como en
breakfast, they will reach
160,
180,
después del
and then
almuerzo entonces
lunch
me va a subir como a
160, and
250,
after
va a llegar
lunch,
a la
they will
cena como en
go up to
200 y después de la
200,
cena me sube como a
250, and
300.
after
Entonces ahí va,
dinner, they will
cada
go
vez un
up to
poquito más alto
300,
durante el día
each
porque
time
no tengo
higher and
nada
higher
para
during the
manejar esas
day,
glicemias
because
postprandiales.
I don't have
En
anything
cambio,
to
si
manage
yo le
that
mantengo
postprandial
la
glycemia.
sulfonilurea,
But if I
entonces
maintain
permite
the
que las
glyceruria,
glicemias postprandiales van a ser
postprandial
menos altas, ¿verdad?
glycemias
Y
will
por lo
be
tanto durante
less
el día va a
higher,
estar
and
mejor
therefore
controlado
during the
porque sus
day,
sales
the
monogénicos
patient
irán
will be
más bajos.
better
Y
controlled
como llega
with
mejor
a lower
después de la
glycated
cena,
hemoglobin,
arrastra menos el alto en la
and
madrugada y por lo tanto la dosis de insulina
during
basal
the
que
night
requiere
it will be
también
less,
es menor.
and
Y
the
esto no solo aplica
basal
para la
insulin dose
sulfonilurea,
he
sino que
requires is
aplica para
less. So
cualquier
this not
ciclosporín,
only
incluyendo un inhibidor de
applies
PP4,
to
por
this,
ejemplo.
but
Entonces, si el paciente le voy
PP4
a iniciar por
inhibitors,
primera
for
vez la insulina
example.
basal, le
And if I
mantengo
will
los
start the
agentes orales,
patient with
a menos
basal
de que haya una
insulin, I
contraindicación. Por
maintain
ejemplo,
the
quitarle la
oral
metformina
agents unless
por
there
falla
is a
renal o
counterindication,
por intolerancia, pero
maybe
de lo contrario, se lo mantengo.
retrieve the metformin due to kidney
Antes
failure
de
or
que
intolerance.
empezaras a dar tu disertación, comentábamos acerca de la
Before you
preservación de
started your
las células
presentation, we
beta en los
were
diabéticos tipo
talking
1. ¿Qué
about
nos puedes comentar al
beta
respecto?
cells in diabetic
Sí,
patients. What can you tell
esto es
us
todo un
about
área y yo
this?
creo que es
Well,
sumamente
this is an
interesante y es donde hay
area
un
which
poco
is
más
very
de
interesting,
avance.
and here the
En
more
diabetes tipo
progress
1
has
realmente
been made. In
acuérdense
type
que hoy en
1
día se clasifican
diabetes, it
diferentes
seems to
estadios,
be that
entonces
different
el
stages are
estadio 1 es el
classified.
paciente que tiene
So
algunos
stage
dos anticuerpos
1 is the
positivos pero están
patient that has
normoglicémicos. En
at
el
least
estadio 2
two
son aquellos pacientes que ya tienen disglicemia sin tener criterios
two
todavía de
positive
glicemia normal menor de
antibodies,
126 y
and
el
they
estadio
have
3 es el sintomático, el que
stage
ya tiene
3
más de
is the
126
patient
o el
that
que ya
is
viene con
asymptomatic
síntomas, ¿verdad?
with
Con
already
catabolismo o
has
cetoacidosis.
systems with
Entonces, hay diferentes
catabolism
estudios en estadio
or
2
acidosis.
tratando de mantener
So
la
we have
función de la
different
célula
studies
beta.
in
Y el que
stage
está
2
aprobado,
trying to
digamos, es el
maintain the
anticuerpo
function of the beta
anti-CD23, que
cell.
es
Now, what that
teclistamab.
has been
Lo que pasa es que
approved
no existe en ningún
is
país en América Latina.
anti-typo
El costo
is
es inaccesible. Esos son alrededor de
the
$200
cost
mil
is
dólares la terapia de
unaccessible in
infusión de los
Latin
14
America.
días de
It's about
teclistamab. Pero
$200,000 for
resulta
the
que hay
therapy
estudios con
of
verapamilo
Cefiximab, but
y
we have
en
studies with
pacientes recién
verapamil,
diagnosticados. Entonces,
and
estadio
in
2,
patients that
estadio
have
3.
been
Y
recently
verapamilo
treated
240 miligramos al día
in
a la
stage
vuelta de
2 and stage
24
3. We
semanas
have
logra
240
preservar
milligrams per day
parcialmente la
of
función de la célula
verapamil,
beta.
preserves
Entonces,
the
esto
beta
es
cell
fundamental porque
function. And this
se
is
sabe que para
fundamental
pacientes con
because
diabetes
we
tipo 1,
know that
todo
patients
lo que
with type
nosotros
1
logremos
diabetes,
mantener de función de células beta se traduce
everything
en
that we
menos
can maintain
variabilidad, ¿verdad?
in
Y
beta
menos
cell
hipoglucemias.
function is
Entonces,
traduced
tal vez no
into
tengamos tanta
less
diferencia en hemoglobina
variability and
glicosilada, pero todos los que
hypoglycemia.
tratamos diabetes
Maybe
tipo
we
1
don't have
sabemos que
that
el
much
tipo
difference
1 que
in
mantenga un
glycated
poquito de secreción
hemoglobin,
se
but
mantiene
we
mucho
know that
mejor, mucho
type
menos
1
lano y mucho
diabetes
menos variable,
with less
¿verdad?
secretion
Entonces,
and
ahí
less
se ha demostrado que
variable.
la
So
función de la
here it's
célula
been
beta es un
shown that
poco
the
mejor con
function of the
verapamil.
beta
Un
cell
medicamento
is a
viejo,
little
en
well
general muy
with
tolerable,
verapamil.
incluso
It's a quite
en
old
población
drug, well
pediátrica
tolerated.
el estudio
In
incluyó y utilizaron
pediatric
240
population, we
miligramos
use
diarios
250
y no les pasó
milligrams
nada, no se
daily,
hipotensan.
and
¿Cuáles
nothing
fueron los
happened
efectos
to
más
them. They were not
complejos y más comunes de
hypotense.
verapamil? Terminan
Remember
siendo
that the
estreñimiento y
most
edemas,
adverse
que son
action,
efectos adversos muy
our
lamentables. Entonces, yo en lo
counterindications
personal
are
sí
edemas,
lo estoy tratando de utilizar un
and
poquito más en los
we
pacientes
have
recién
manageable
diagnosticados porque yo
adverse
creo que eso me
actions.
ayuda
And
a
I
mantener
personally
la
have
función de
been
la célula
using
beta.
it with patients that have been
Pero
recently
aclarar entonces,
diagnosed.
aclarar
For
que esto es
the
diabetes tipo
beta,
1, ¿verdad?
I
Diabetes
need
tipo
to
1.
clarify that this is
Y
for
otra opinión de
type
la doctora
1
Luz
diabetes. There's another question
Barco, su
from
opinión sobre la
Dr.
insulina por
Luz,
conteo de hidratos de carbono.
the
Ok,
direct count
esto es
of
importante.
carbon count.
Cuando estamos
Yes,
hablando de la
that's
estrategia
important. We
de insulinización
refer
durante la
to
presentación,
the
nos enfocamos sobre
insulinization.
todo
During
para
my
diabetes tipo
presentation, we
2. En
focused
diabetes
on
tipo 2, el
type
conteo de
2
carbohidratos no ha
diabetes.
demostrado
Here,
ser tan
the
efectivo como en diabetes tipo 1.
carbohydrate
Para
count has
pacientes con
not
diabetes
shown
tipo
to
1,
be so effective. With
definitivamente
type
es
1 non-diabetes patients, it's definitely important to counter carbohydrates. Why is this so? Because evidently the amount of prandial insulin the patient requires is in close relation to the amount of carbohydrates he is consuming. So, for example, if they have breakfast in Mexico with lots of chiloquile or beans plus tortilla. It's too much carbos. So we already know there's a limitation of the hybrid carbs count regarding education. Not all of them have access to nutrition. Not all of us have time to dedicate time to patient education. So one of the practical things I try to do with my patients is that I ask them to be consistent with the carb amount. Instead of counting whether it's 35 or 40 or 50 grams of carbs they're eating, all breakfasts must always have more or less the same amount of carbohydrates. And what will vary if they have more or less hunger can be proteins or vegetables without carbs. So this facilitates a little the
Otra
amount of
pregunta, tal vez
insulin that
más aquí
we will be
práctica, ¿cómo
applying.
actuar ante la
I
omisión de
have
una
another
aplicación de insulina semanal?
question or regarding a weekly insulin application. Here, there's no problem at all. From the pharmacological standpoint, to eliminate the drug, we require 4 to 5 half weeks. So if we say that if drug has a week half-life, this doesn't mean that the patient will have a hypoglycemia. So if the patient is injected on Sundays and he forgets to inject on that Sunday and he was outside his house, if he applies it on Monday, for example, he will still be in a stationary period. So there's not much difference, or there's no problem at all of doing it one day earlier or one day after. This we've seen already in weekly medications with GPL, for example. We don't see there's much difference either on the 8th or the 6th day. What we can tell the patient in case of omission, apply it when you remember that you forgot the application, when you forgot the doses. Potentially, if we see, strictly speaking, for the US, Icodec has not been approved for diabetes, type 1 diabetes, but if it's an action duration so prolonged, maybe the risk of cytosis with those medications, because the risk of omission and the patient will be totally insulin-panic. We need to show this, we need to prove this, but theoretically speaking, it could be a benefit. While the counterpart, without reaching the stationary state, if I have a patient with catabolic symptoms, with polyuria, polydipsia, it's maybe not the best candidate because he will take too long to achieve the stationary state. So we will need to have to use a low dose, or we to be a little bit more aggressive. If the patient comes in catabolic, probably I would have to start with a basal insulin daily and then before
Otra
doing
pregunta
the
de la doctora
transition.
Natalia Reyes.
Another question from
Tomando
Dr.
República de Chile, en
Natalia
personas que ya
Reyes
usan
from
insulina basal
Chile,
más un GLP-1, pero tienen glucosa
plus a
por parte del
GPL-1, but they
0%,
have
¿cómo
postprandial
iniciaría los bolos? ¿En todas las
glycemia? How
comidas
would
o
you
solo
start the
donde está el
bolus in
alto?
all the foods,
¿Alguna
or only
recomendación de
where the
unidades por kilo
high
bolo?
is?
Saludos desde Chile.
Any recommendation you would make regarding the bolus per kilo? I would start with sequential boluses. The strategy would not vary. Sequential strategies, sequential boluses have proven to be efficient. I would see then two ways of doing it. I will see at what time of the day the patient consumes more carbs, and I would have a zero 0.1 unit per kilo dose quick or fast insulin. For if the patient weighs 80 kilos, I would put 8 units of insulin. Or maybe if the person is outside his home and he doesn't want to take the insulin with him, the first study showed that regardless of the time of the day when I added the first bolus, the efficacy is the same. Maybe in the morning, the patient eats less carbs. I can add those 8 insulin units before breakfast. And why does it work the same if the patient is eating less carbs? Remember the ALBA phenomenon. In the morning, due to the release of the counter-regulating hormones, due to the adrenaline growth hormone, and this typically makes the morning dose to be higher in spite of eating less carbs. So 8 units a day, for example, 0.1 unit per kilo, regardless if it's breakfast or lunch or one dose, and after 2 weeks the patient does not reach the target, I add a second dose, and so on.
Ok, ¿algún comentario acerca de diabetes
Any
gestacional,
other comment
metformina, insulina?
regarding metformin, insulin, stationary diabetes? Well, strictly speaking, if we go with what's approved by the regulatory agency, they should be insulins, and insulins that are approved, strictly speaking, by label for pregnancy are basal, are NPH and degludec, the ultra fast, all of them, metformin. We all use them empirically. There is not much data that tells us that it gives us problems, but regulatory speaking, it has not been approved for pregnant women. Metformin has been evaluated in gestational pregnancies and sulfonylureas, bibenclamide, which has less transplanetary. For diabetes type 1, obviously it will be insulin. We have no oral agents do not play a role. The betamide, degludec are the ones that degludec are approved for pregnant women or for pregnancy. Most of us who have type 1 diabetes, if I have a patient with glargine, I do not remove the glargine because the patient cannot be decompensated. And in spite of the fact that there's no approval, we have lots of empiric evidence. So please maintain the scheme for gestational diabetes or type 1 diabetes. I think that according to the regulation of each country locally, metformin have nor like glibenclamide have been approved. And why I insist on this, it has never happened to me before. If the newborn has any complication, they could demand the doctor for treating with a drug that has not been approved for the indication in that specific country. So here, I think we have to be a little bit
Desde
more
Uruguay,
careful.
nuestra colega Cristina
From
Alonso,
Uruguay,
saludos
our colleague
Felaen.
Cristina
Hola Cristina,
Alonso.
te
Hi,
agradezco.
Felaen.
Comenta manejo del
Hi.
efecto del alba e
Please
hiperglicemia
manage the
post
effect
ejercicio.
of ALBA post-exercising.
Eso es complicado, eso es difícil.
That's very
Con el efecto del
complicated.
alba,
It's too
digamos,
difficult
dependiendo
with
de qué
the
está utilizando
effect
el
of
paciente.
the morning,
Si el
depending on
paciente
what
está
the
con un
patient
basal
is
bolo
using.
completo y está
If the
con algo
patient has
basal,
a
entonces está con
bolus,
glargina, degludec,
full
tetemid,
basal bolus, if
es muy
they're
difícil
using the
manejarle
gludec, it's
con esa
very
insulina basal,
difficult
¿verdad?
to
Entonces el
manage
paciente, digamos,
basal
ahora que tenemos
insulin
los sensores, el
consequence.
paciente
So now that
está,
we have the
no sé, pongámosle 100, 110 hasta las 3 de la mañana y a
the
partir de las
patient
4
had
de la
100,
mañana empieza a subir,
110
subir,
up to
subir,
4
subir
a.m.
y
and then it
amanece en
starts going up
160.
and up,
Entonces,
and he
la
wakes up with
limitante ahí es, si yo le
160. So
aumento la
the
dosis de la insulina
limitation here is
basal, en
that
la madrugada me lo va
I
a bajar más, me
increased
corro
the
el riesgo de
dose
hipoglicemias, ¿verdad? Y si lo dejo así, el paciente se
of
frustra
basal
prácticamente, ¿verdad?
insulin in the
Ahí
morning,
era
the
donde
patient
la
will be
NPH podía
frustrated
tener alguna
because it will be
ventaja,
too
digamos,
high. So
precisamente
here
por
the
el pico de acción. Si
GPH
se lo
might
aplica a las 10
probably
de la noche
be
y el
have
pico
some
de acción es a las
advantage.
6 a 8 horas después,
If
entonces
it's
el pico
the
de acción me lo
peak
va a estar haciendo
is
entre 4 y 6 de la
between
mañana.
6 and 8
Entonces
hours, then
ahí
the peak would be between
podría
4
ser,
and
¿verdad?
6
Entonces podría
a.m.
ser que la
Then
NPH tenga
it could
alguna
be that
ventaja
the
por ese
NPH
pico.
might have an
Y lo
advantage
segundo
because
entonces
of the
es
peak. And the second thing is
la
that
forma más
the most
sencilla, que no necesariamente es
simple
lo más
way that not
accesible para
necessarily
manejar
is
ese
the most
fenómeno del alba,
accessible
entonces
to
se
manage
recomienda que
that
hagan
phenomenon in the
microinfusores, ¿verdad?
morning is
Yo tengo bombas de
because of
insulina,
the
sea las automatizadas o las no
microinfusers. I have
automatizadas.
the
Las
automated
automatizadas, por
insulin
supuesto,
pumps.
me la
The
voy a autocorregir,
automated, of
pero
course, will
si no, entonces yo le
autocorrect
puedo
it.
programar
But if
diferentes
not, I
basales
can
para que después de
program
las 3 de la
different
mañana le suba la
basals so
infusión
that
y
after
tratar
3 p.m. the
de que
infusion
tenga
goes
menos
up
el fenómeno
and
del alba.
try to have
Entonces,
less
eso es
morning
mucho más
phenomenon.
retador, como le digo, cuando estamos utilizando
This
insulina
is
basal.
a greater
La segunda pregunta en
challenging
relación a
or
la
more
hiperglicemia post
challenging
ejercicio.
when we are
Hay que
using
recordarnos
insulin.
dos
So the
conceptos
second question
importantes.
is
Según el
that
tipo de
we need
ejercicio
to
que vamos a
remember
tener un
is that
impacto en la
according to
glicemia.
the type of
Ejercicio
exercise,
cardiovascular, en
if
general,
it's a
las glicemias tienden a
general
bajar.
cardiovascular
Ejercicios de
exercise,
resistencia, pesas,
glycemias
¿verdad?
tend to
Tienden
lower
a
down.
aumentar.
If it's resistance exercise, they tend to increase it. So according to what the patient does, if the patient lifts weights, one, he might probably not eat before his exercise session, or two, try the patient to start patients begin exercising when their glucose is as close to normal, or a small correction in their insulin. Or if the patients combine their exercise, they could start with lifting weights, and if it goes up a little, and then if they continue with cardio, then cardio with lower it. We need to remember that in general terms, we we do not recommend patients to correct glycemia during the first 60 minutes. We need to start the hydration, the regulating hormones, and adrenaline and cortisol. So if they start exercising in 200 and then I add insulin, usually I don't recommend that they wait less than 60 minutes before correcting this in order to avoid these glycemias post-exercising.
Ok, daremos paso
Very well, then we will now give the floor to
al doctor Cavallo para que nos dé las
Dr.
palabras de cierre del evento.
Cavallo for
Posteriormente,
his closing
haremos
remarks.
presentación de la siguiente jornada que tendremos
And
el día de
after
agosto.
that, we will
Bueno,
talk about the
muchísimas gracias. Primero
next
que todo, a los
webinar
más
we
de
will
30
have on
participantes por
August
estar este
the
sábado en
10th.
la mañana aquí con
Thank you
nosotros.
very much to all
Agradecer al
participants
doctor Chen por
attending.
siempre la
More than
disponibilidad
80
de
participants we
este
had this
tipo de
morning.
charlas,
Thanks to
excelente
Dr. Cheng
presentación. Eso que
for his
seamos de pediatría,
availability
como
for
yo,
these types
yo
of
pasamos
seminars.
mucho y nos sirvió
Even if
muchísimo
we
también.
are pediatric
Vamos a repasar el tema
specialists,
de
it's
la
very good
pandemia.
for us.
Es un tema interesante, lo de prevención.
We
Es
will talk
algo
about
que
another very
está
interesting
muy en boga
topic.
y de mucha investigación.
There's
Y
much
agradecer a FELAEN,
research.
¿verdad? Y a la doctora de la Peña por siempre estar
Thanking
dispuesta
Dr. De La
a
Peña
dar
and
este tipo
Felaeng
de
for always
conferencias
being
y
willing
la promoción de
to
la salud a nivel
conduct
del
this
área,
type of
porque como hemos
conference
dicho al
and health
principio, hace
promotion in
muchísima
this
falta.
area.
Y de verdad,
As
muchas
we
gracias
said
a todos.
before at the
Vamos a hacer
beginning,
la presentación
we are
y
missing
al
this,
doctor
and
Napoleón también por estar aquí
thank
en
you
la mañana
very
con
much.
nosotros.
And
Y
thank you,
hacer la
Dr.
presentación de la
Napoleon,
próxima,
for being here with
del
us
próximo evento.
this morning. And this will be the
Ok, gracias a
presentation
todos, en
for
especial
our
pues, a Chen por el tiempo y la
following
dedicación que siempre
events.
dedica a todas sus
Thanks, Dr. Cheng, for
presentaciones,
your
muy,
time
muy
and
buenas presentaciones.
dedication. Very,
Nuestro
very good
próximo evento será
presentations.
el 10
So
de
our next
agosto
event will
y
be on
es
August
siempre
10th.
conversando con el experto. A
And
cargo del
always
doctor
talking to the
César
expert, it
Ivanato,
will be
nos
conducted
estarán
by
hablando acerca de
Dr.
los
Cesar
tratamientos actuales
Ivanarti. He will be
futuros
talking
de
about the
osteoporosis.
present and future
Contaremos con
treatments. We
la
will have
presentación o
a
colaboración de nuestra
presentation or
vicepresidenta
collaboration
actual de
by
FELAEN, la
our
doctora Pilar
current
de la
Felaine
Peña,
Vice President,
nuestro
Dr. Pilar de
past
la
president,
Peña,
el
and
querido
our
amigo,
past president,
doctor
our dear
Pedro Anel
friend,
Rueda.
Dr.
Ustedes están
Pedro Anel
cordialmente
Rueda.
todos
So
invitados a
you are
participar
all
este próximo
cordially
10 de agosto.
invited to
Igual
participate
pueden encontrar
on
mayor información
August 10th.
en
And
Facebook,
you
en la
can
página
find
web de
more
FELAEN, en las
information
redes
on our
sociales,
Facebook
donde
page
podrán
and
inscribirse previamente al evento
in
y mandar sus
our
preguntas con
Felaine
anticipación.
page, where
Los
you
esperamos
can
nuevamente el 10 de agosto
write your
y les
comments or
deseamos un
questions.
feliz fin de semana.
We all
Muchas
expect
gracias
you
por
then on
participar de
August the
estos
10th, and thank you
magníficos
very much for
eventos
your
de educación médica
participation
continua.
in this
Feliz
great
día para todos.
medical
Gracias.
events. Have a nice day, everyone. Thank